Hello, my name is Tobias. I'm a specialty registrar in otolaryngology head and neck surgery in Copenhagen, Denmark. I would like to present a study with the title A Randomized Multicenter Clinical Trial of Transoral Ultrasound versus Standard of Care in the Diagnosis of Peritonsillar Abscess. Peritonsillar abscess is the most common deep neck infection, and it can be difficult to see the difference between an deep neck infection and an abscess on the clinical examination only. The treatment is either needle aspiration or quinchy tonsillectomy. The preferred treatment in Denmark is currently needle aspiration, but due to the difficult diagnostic workup, a lot of needle aspiration attempts are unsuccessful. Instead, transoral ultrasound can be used as a point-of-care imaging to improve the diagnostic accuracy. Previous studies have described a technique using an endocavity transducer for the diagnostic workup. However, the endocavity transducer is quite big and it's not possible to do an ultrasound-guided needle aspiration. Instead, I've been working on a technique using a smaller transducer, seen here as a neurosurgical transducer, and a flexible hockey stick from BK Ultrasound. Looking at the ultrasound image, you can see here an inflamed tonsil without an abscess, and on this image you can see an abscess cavity before and here after drainage with a needle aspiration. With the use of the neurosurgical transducer, you can attach a needle guide so you can reach the abscess cavity and do a drainage very precisely, which I have described in a previous paper. Here you can see a patient with a peritonsillar abscess, and I put inside the neurosurgical transducer with a needle guide, and here you can see the line coming here and the needle going into the abscess cavity, seen here, and the nurse are asked to do an aspiration of the abscess. If the patient have troubles with opening the mouth, it may not be room enough to put on the needle guide, and instead you can use a freehand technique where you put the ultrasound transducer on the peritonsillar swelling, and you can guide the needle inside to the abscess cavity and start the drainage. So the research question for this study was if we could use transoral ultrasound to improve the diagnostic accuracy and decrease the number of needle aspiration attempts performed. So we performed a randomized controlled clinical trial at two different centers in Denmark, the Department of Otolaryngology and Head and Neck Surgery at Rigshospitalet Copenhagen, and the Department of Otolaryngology Head and Neck Surgery at Odense University Hospital at Fyn. Patients suspected with peritonsillar abscess above 18 years were asked to participate in the study and were randomized to a clinical examination or a transoral ultrasound. Before we started the study, we trained all the otolaryngology residents on call who would see the patients with a peritonsillar abscess, and for the purpose I developed a phantom with some balloons inside, and all the residents performed an ultrasound guided aspiration of the balloons, both with the needle guide on and with the freehand technique. Further, they also received a 30 minutes lecture about transoral ultrasound and different cases. The patients were either randomized to the ultrasound or the control group. If there was an abscess suspected in the ultrasound group, there were performed a needle aspiration either with the needle guide or with the freehand technique. If no abscess were suspected, the patient were treated with antibiotics and follow up in the outpatient clinic. In the control group, the same treatment were given to the patients without suspect abscess, and if there was a suspected abscess, they will also have a needle aspiration performed. However, it would be without ultrasound. So in the study, we enrolled 96 patients, and 47 were allocated to the intervention group and 49 to the control group. and 46% of the patients in the intervention group were treated with needle aspiration compared to 97% in the control group. And we found a significant decrease in the number of needle aspiration performed at the first visit in the outpatient clinic, and also a significant decrease in the total number of needle aspiration performed after ending the treatment and follow-up in the outpatient clinic. Looking at the diagnostic accuracy, we found an increase from 33% in the control group to 81% in the intervention group. However, doing logistic regression, we didn't find power enough to a significant increase. Looking at the secondary outcomes, we found that there were no difference in the number of visits in the outpatient clinic or the number of sick days between the intervention and control group. However, we found that trend towards more of the patients in the intervention group were admitted to the hospital, which may be explained that more patients in the intervention group had quinchy tonsillectomies performed compared to the control group. Looking at the needle aspiration in the intervention group, we found that half of the needle aspiration were performed ultrasound guided. There were 28 different physicians treating the patients in the study, and 33% of the physicians answered that transoral ultrasound did improve their diagnostic workup. A limitation to this study is that some of the physicians used quinchy tonsillectomy instead of needle aspiration for treatment of peritonsillar abscess, and because of they saw the abscess cavity on ultrasound, they didn't perform the needle aspiration. Further, we had 28 different residents performing the procedure unsupervised because the patients are coming on call. So many of the residents didn't get a lot of experience with the ultrasound before we ended the study. Another limitation may due to the technical issues with the ultrasound guided aspiration, because they used a longer needle with attachment to a syringe. Some of the cases found it difficult to aspirate all the pus in the abscess due to a less pressure when using the syringe. There's one other randomized controlled trial comparing ultrasound to clinical examination of patients suspected for peritonsillar abscess, and they found a 100% diagnostic accuracy of using ultrasound. However, they only included 28 patients, while we included 95 patients, and they had a single center study while we have a multicenter study. Further, they had some few experienced attending emergency physicians to supervise the residents on call for each procedure, which would not be the clinical situation in Denmark. So the diagnostic accuracy we found in our study was a bit lower than this study, but we find it more realistic to a clinical setting with a lot of different physicians taking the on-call calls. So with this study, we can conclude that transoral ultrasound can reduce the number of unnecessary needle aspiration attempts in patients suspected of having a peritonsillar abscess. However, more training may be needed to decrease the number of false negative and to perform ultrasound-guided aspirations technique of the physicians on call. Thank you very much for your attention.